if you do it like that, it makes it a little bit easier to identify one, because you can look for the sound. So we're going to go for price transparency. Mystify price transparency. Hey, everybody. We are the Payerset team, Jacob and Jerry. Hello.
Hey.
Today we're going to talk about price transparency, sort of give an intro to price transparency. We get a lot of different prospects and customers that come through our website, and they all have sort of different levels of knowledge about price transparency. In some cases, they have a good understanding of the mandates that were put out by CMS and the Department of Health and Human Services. In other cases, they are tangentially aware of it, have heard the term, not really sure exactly what it is. In some cases, people have tried to actually go get this data and met some of the challenges we'll talk about today. So we just want to kind of take a step back and talk about what price transparency is, give an example of how we take this price transparency data and parse it and make it usable, and then talk a little bit about why it's such a huge challenge in the space.
Yeah. I really well said, Jerry, around all of the different kind of people who have come to Payerset very interested in it. And they may have come to us because their boss or their triple boss told them to go take a look at it, right? Or they may have tried it themselves. So I think it's really, but whether it's somebody who's pretty well versed in the matter and has tried to get the data and tried to use the data, or somebody who's just curious, there's definitely been kind of information gaps. And so I think maybe as part of this, taking the step back, maybe we just start with the policy in general, maybe, and when it all happened.
Yeah, that makes sense. When you talk about the differences between, so there's the hospital's price transparency mandate. So all of the hospitals have to put out data that essentially, what is price transparency? Maybe we even start there. Price transparency is essentially a mandate by the U.S. government that hospitals and payers or insurance companies have to publish all of the reimbursement rates that they get for various different services. So if a hospital does a knee surgery, they have to publish what reimbursement rate they get from all the different insurance companies that they have a contract with. What are they getting paid back for that knee surgery?
Yeah.
And that's for every CPT, HCPCS, DRG, NDCs, or pharmaceutical drugs are going to start to flow in. In some cases, they already are. There's all different other types of revenue codes, things like that. Whatever the contract is negotiated, they have to publish those rates of reimbursement for every single service. So you can imagine it's a very large amount of data. Even if you just take the hospital data, that they have their own separate mandate. There's 7,000-8,000 hospitals. They have their own set of rules that they have to publish. And they're not as stringent as the payer rules. So we'll get into that. But the payers have to publish for every single provider that they work with. So it's not just hospitals, it's clinics, physician groups, down to individual physicians, behavioral health centers, things like that. They have to publish everything. So this is a very, very large amount of data. So you want to go through some of the mandates and stuff like that?
Sure. Yeah. Everybody loves looking at laws and final rulings. But we'll just keep it really high level. Let's just pop up this one particular source. This comes directly from CMS. And so the transparency and coverage final rule was released and is being enforced by the Department of Health and Human Services, HHS, and the Department of Treasury. And so CMS has been instrumental in putting out the formats that this data needs to be in, and what values need to be in this data. So as Jerry talked about, there's really two branches. There's the health insurance company branch, the payer branch, right? And those and they have specific requirements, and there's the hospital branch. And so the mix of the information is a little bit different. Obviously, they have different sets of information. The payers have the contracts with everybody, right? Whether you're Dr. Bob in Iowa or HCA Health System or Ascension or a really large organization like that, the payers have all of that. And the hospitals are just the hospitals. And the hospitals also are dealing directly with the patients. And so there's things they have to post in their data, like the discounted cash price for a service and things like that. So it really depends, depending on what you're trying to do and what problem you're trying to solve. You might want to access these different sources. You might want to look at them together and how they play off of each other. But so these two organizations, HHS and Department of Treasury, have pushed out the final ruling. And there's a lot of different stages to it. There's different stages that affect the payers. There's different stages that affect the hospitals. And so on the screen here, the stage that we're talking about is for the machine readable file. So there's a number of things that the different organizations needed to be able to publish. Some are consumer facing, some are for research and data and analytics third party purposes. And the machine readable files falls into that category. And the thing that people really want is that in-network rate, because that is the contracted rate with in-network providers. And what people are doing with this, at least initially, but there's a lot of really interesting use cases around this, is being able to see, okay, for the same service for an organization like mine, what are they contracted to be reimbursed from the health insurance company, from the Uniteds or the Blue Cross Blue Shields of the world, as compared to my contracted rate. And that's important because that rate is really a part of the operating cost of the care delivery organization. So obviously the costs within healthcare are multivariable, complicated. There's a lot of different players, but this is a really kind of important piece of that financial stack. And it is what is the care delivery organization getting reimbursed. And the really surprising thing about this is that there is very, very large rate variation. And that is, hey, for very similar organizations, for same services, in same kinds of geographies, there could be a very large spread. And that's because a lot of times people don't even know where to start when they're negotiating. These prices have been set for a long time. People haven't had access to the detailed data before. And so they're just kind of starting on these many layers of historical negotiations and data. And so this is the first time that a light has been shown on all of this information. People are very excited about it. And then to Jerry's earlier point, people come to us and saying, hey, I've heard about this, but what is it? To, hey, I've been trying to get this information and it's really hard. And I think double clicking into why it's really hard is important. If we go and look at kind of who's required to post this information, all of the big commercial payers are required. A lot of times we get questions, hey, what about MA, Medicare Advantage or Medicare? They are not required to post, even though sometimes you will see MA plans in there. Another thing that Jerry mentioned earlier is the NDCs, the drugs aren't required. They've actually held off on enforcing that since all of this began to be enforced in July of 2022 for the payers. But we'll see that there's actually NDC data in the MRFs as well. So some payers are ahead of the curve. Also, adding these different fields and these different rows makes the data incredibly large, so large that it can't be opened unless you're using kind of special approaches and technologies and servers and things like that, kind of getting into why it may be difficult. So this is who is not required to meet these transparency and coverage requirements for the MRFs. But all the big commercial payers are, where all of the money is and all the activity is and all the contracts are. And so with that, we talked about kind of what it is, high level, how people will use it, even though the use cases for this data are vast, and we learn and hear from more almost every week as people come through our website or reach out to us and want to talk about this and brainstorm with us on how they can use it. And so just kind of, Jerry, when we talk about this data and why it's hard, maybe I think it makes sense to step back and talk about how it's structured.
Yeah. So each payer has to put out, they don't necessarily have to put out a table of contents, but most of them do, at least the larger payers. The Blues do, United, Aetna, Cigna. Most of the payers have a table of contents. And this table of contents is essentially a list of all of the files that the payer has put out that contain all the negotiated rates and the allowed amounts. So there's some nomenclature there too. So a lot of times people will call allowed amount the negotiated rate. What health systems typically consider allowed amount are a concept called in-network negotiated rate in the machine readable files. There's also allowed amount, but that's applicable to out-of-network. So there's some nuance there, but the data that is really the important data is called in-network rates. And so each of these machine readable files contain information about the provider that the rate is for and information about the actual rate itself. And we'll get into what that looks like. But each payer typically has a table of contents that will contain all the plan information in it, or the network. Sometimes they're called networks, sometimes they're called products. Network is a little bit different than plan.
Yeah.
So there is a lot of nuance to this data, and depending on how you're thinking about it, the networks may or may not map to specific plans. So an example of a plan would be like Aetna Choice POS2. That's an example of a plan, but that's not a network that Aetna has, although you could call it, and some people do call it network, some people call it a product. But like I said, there's some nuance to how the just the nomenclature works for these files. So that's where we're trying to kind of get to right now. So it starts with the table of contents. Table of contents will have a plan name in it, and then we'll have a reference to a machine readable file, typically hosted on some server. These files can be extremely large, upwards of multiple terabytes compressed, uncompressed, even more than that. And we'll show you. I should probably open up, show an example maybe.
That'd be cool.
Of those that may help. So let's start with a table of contents. So you have table of contents, and those have plan groups, and then there's individual plans in there. Let me just pop my screen. I'll open up Blue Cross Blue Shield Alabama's table of contents. Here we go. All right, so you should be able to see this.
Yes.
So this is a file, an index file. That's what they call them. So there's table of contents files. In some cases, payers have many tables of contents files. Aetna and United have thousands of tables of contents files. Some of the Blues only have one. Some of them have a few, but they're typically named like this: Blue Cross Blue Shield Alabama _ index.json. So these are JSON files, just the data storage file structure. And in here, they'll have who the reporting entity name is. So in this case, it's Blue Cross Blue Shield Alabama. If there's other entities that are reporting on behalf of another payer, for example, in some cases, Aetna does the reporting for smaller payers. So that can happen. But in this case, it's just Blue Cross Blue Shield of Alabama. And in here, we have the reporting structure. So this is the plan structure. In each one of these substructures here, we have a list of the reporting plans. So you'll see in this case, this is A.W. Herndon Oil. It's an EIN plan. So this is for a specific employer. And then we have the in-network file information. So you can see in this particular plan, for this plan, there are lots and lots of individual files. So these are links to these files. You see this is 1 of 29, 2 of 29. And so these are all individual files that pertain to this particular plan. So this is an EIN plan, so it's for a specific employer. If we look for a HIOS plan, for example, you'll see that there's like Blue Choice Platinum for Business PPA plan. And this has a similar structure where it's got an in-network file. In here, these are just links to all of those files. And you'll see that this is actually probably the same as that EIN plan. So these tables of contents often link to, for the same plan, the same files, or for different plans rather, the same files. For Blue Cross Alabama, I think there's maybe 700 or 800 distinct total files, but there's many thousands or millions of references to those same files.
What does that mean? Why would they all be pointing? Why do you have a bunch of plans pointing to the same files?
So what that means is that each of these plans just has the same rate for the same billing code for the same provider.
Okay. And that makes sense because they would be using probably some handful of kind of foundational rates and whether it's probably the same networks, same rates. They're not going to be doing custom. They're not going to be doing custom contracts for every single employer in the United States. It makes sense they'd be reusing from some base set of rates.
Right, and they're typically doing the negotiation with the providers on behalf of the regional employer plans that they have.
Okay.
So there's and I also kind of went quickly over this, but I just searched for HIOS. This is a plan type. So there's either EIN or HIOS type plans. EIN plans are specific to employers. HIOS plans can be more generic, though they're not explicitly always more generic. Sometimes there are HIOS plans that are specific to employers. Kind of depends on how the payer interpreted the rules. And that's for a lot of this data, right? And that's part of what makes it so difficult is that the mandates are specific, but they're also open to interpretation. And so each payer has done something differently based on how they've interpreted what the rules are. Over time, we think that standardization will get better. But for now, each payer followed sort of different, even within the rules, different interpretations of the mandates.
Interesting.
Yeah. But this is what a table of contents file looks like. So this is a 320 megabyte file that just contains a list of links to the real data.
This is a treasure map.
Yeah, this is your treasure map. And again, this is just one payer. And obviously there's over a dozen Blues. There's hundreds of payers in the United States. And they all have sort of slightly different ways of doing this, even listing their table of contents. Or in some cases, they don't even provide a table of contents at all. They have a list of files on their website, which is allowed, but does make it a little bit more challenging.
So this goes back to the interpretation of there's the ruling, and then there are the rules that are documented, but there's still gray area to play in within those on how you interpret.
Right, exactly.
Okay.
So this is what a table of contents file looks like. This isn't even the actual data at this point. But let me open up a real machine readable file here. So this is one of the smaller machine readable files. It's 2 gigabytes. And you can see kind of the structure of how it works. So this one is Blue Cross Blue Shield, South Carolina. Just trying to find a small one that I could actually open on my machine. And you'll see that there's 2 sections here. There's provider references, and then there's the in-network files or in-network data. So these are the 2. They're not always like this, but these are the 2 sections of the file. So they'll have a provider references section. This is essentially a list of all of the providers in this file, and they'll map to a group ID. which is then referenced in the negotiated rate, because oftentimes providers have the same rate for the same service.
Right.
So for this particular ID, there's, that maps to this NPI under this TIN.
Okay. Interesting. So you have the National Provider Identifier ID and the kind of the tax, basically the tax EIN identifier, all kind of grouped together. So they're basically the NPI and then the official organization's tax ID.
Yes. Yeah. Okay. Exactly. So this could also be an NPI, not an EIN, but it's their tax identification number as they have it in their contract or in their relationship with that particular provider.
Got it.
And you can see there's lots and lots and lots of these. There's probably many millions of them. And these all key off of this provider group ID. So if we search for this provider group ID, there'll be one instance here, obviously, and then there'll be one instance somewhere else where there's a provider reference ID and then the negotiated rate that goes along with that. So in this case, for that first provider reference, you'll see that that is for this particular service. Let me just expand all of these. So this is the provider reference. You'll see in here the negotiated type is negotiated. We'll get through some of these field details, but this is the actual rate. And I know that you don't see any billing code in here. That's because the billing code is actually up. And this is what the billing code is that we're looking at. So it's billing code ATP08. It's a HCPCS code. It's for automated multi-channel test, some maybe lab test here. And then all of these rates underneath it apply to this particular code. So for all of those providers we looked at before, this list of providers here, all of these NPIs, 15083, 18513, etc., all of these NPIs have this rate, $10, for this billing code, ATP08. So you can see why it would be very challenging to get this data in any sort of easy to use format.
This doesn't look Excel friendly, I'll tell you that much.
It's not Excel friendly. Yes, it's definitely not. It's not a spreadsheet. So even if you know very specifically what you're looking for, to navigate a file structure like this is very challenging.
Well, you're just in one, and like you said, there could be 1,000.
This is just one file. Blue Cross Blue Shield South Carolina may have 600, 800 files. I think Blue Shield California has almost 4,000 files. Aetna has 5,000 files.
Wow. Okay.
And they're all much bigger than this 2 gigabyte one, right? So even if you could do this for this one, most of the Aetna files are huge, 10, 20, 30 gigabytes or up to a terabyte. So you're not going to be able to even open these files.
There's also no rhyme or reason on how they're distributed across all of the files, right? So you have to have all of the files to know that you have the right answer.
Yeah, and that's one of the I think one of the bigger challenges is like you can't know that you're not missing something, or that you don't have even an old rate or a different rate if you don't have all of the data. So you kind of need all of it to be able to know that you're not missing anything, because there's no real indicator of that. So this is what a machine readable file looks like. And like I said, this is one of the smaller ones, but it does have the billing code and the negotiated rate, and then a link to the specific NPI that rate applies to. So all the data is there. It is just very hard to get to. Even if you have tools like this as a JSON reader tool, that is very good, but it's not going to open a file that's larger than what memory you have on your computer. So this is just one of the challenges that exist.
Really interesting. And I saw there was other fields in there that seemed like they'd be important. Like there was an expiration date. So I guess that's the expiration date of the contract. And a lot of other pieces.
Maybe it makes sense to show. So we see the source data. So this is a very difficult sort of thing to get to, but you can read it. It's plain, it's there. Maybe it would make sense to try and show an example of like a finished. So we get all of this data. That's what when we do this. We do it quarterly. We parse all this data and we turn it into that Excel-friendly spreadsheet type. But it's still absolutely massive, right? So you're still talking about trillions and trillions and trillions of rows of data. So not something that could fit inside Excel, not even close. Even enterprise databases would struggle in some cases with the volume of data that this is, and especially when you actually join it all together, which is if you were to, you saw that there was kind of one rate that was applicable to hundreds of NPIs. If you actually join all that data together, you're talking about quadrillions of rows or quintillions of rows of data, some extremely large number that no database could actually hold together. And so you need sort of these techniques to be able to make this data even visible. And then you also need to be able to make it usable. And that's one of the things that like we focus on. So maybe we can show an example of like a finished analysis.
That sounds good.
Does that make sense?
Yeah, that makes a lot of sense, because I think in my mind's eye, I'd want to see a row with the provider, the NPI, the TIN, a rate, a billing code, a modifier, expiration date, and then what plan or plan type. I want one row, and then I want to be able to sum and average and compare and do all of the things that analytics these days can enable us to do with this insurance rate data.
Yes, exactly. So, all right, I'll pull that up in a second. If you are interested, we do have all of these files, all the tables of contents files. You'll see Aetna, I mentioned before, they have thousands of tables of contents files. So you've got to pull down all of these table of contents. So you see these are all index files. You got to pull down, there's 1,755 of them. United has
contents. Wow. Okay.
40,000 or 48,000, something like that. So each of these files is just contains a list of file links. So, but if you're interested, we do edit all audit all the payers, and we have all the links to their tables of contents. You can see like Aetna has, this is for February, they have 2.5 trillion rows of data.
Just in their rate record. So this is kind of what you were saying earlier. If you join those rate records on the top to the provider records on the bottom, that's where the data is already massive, but then we're getting into insane amounts of information.
Right, exactly. So, but it's all here. If you want to just take a look at some of these files, see if you can open them.
Notice some people are orange and some people are red. Interesting.
Yeah, yellow, orange, green. We try to be lenient if we can. We don't want to. We do think people are trying to follow the mandate.
There's a lot of green. That's the good news. There's
a lot of green. Aetna is tough because they have all those different table of contents files, but their data is very good and it's of high quality. We've been able to tie it down back to the penny with actual real contracts that people have in. So this data is good too. I think there's a lot of we meet with a lot of people who say like, oh, it's not really, the data is not good quality. It's not really usable. That's not correct. If it's not complete, then yes. But this data is definitely, not in all cases, but for the major payers, the data is accurate, and it's just hard to wield.
I think it's also been a journey. So we're in this data has been available for almost 2 years. So when you think about that, I guess the question is, when did you last look? Maybe that's another good question.
Right. Or actually, do you have a good example to show?
Yeah, I've got one. Let's look at a big state.
Okay, let's do this here. Let me add you here. All right, you're up.
All right. Everything's bigger in Texas, including rate variation. All right. So what we're looking at here is around 4,500 negotiated rates and 99 providers. This is looking at hospitals and clinics in Dallas and Austin and Houston. And we're looking at a handful of codes here: 470 major hip and knee joint replacements, 27447, emergency department visits, CTs, those kinds of things. And so let's look at this data flattened first. And we were talking about this before, and we saw it in the MRFs. There's some important information that you can filter and normalize by. So I just want to look at institutional rates. I want to filter out professional rates. We've got them both there. We've got about 1.1 thousand professional and 3.4 thousand institutional rates. So we'll look at that. Let me just focus on 27447, and we'll keep the modifiers in for now because I want to see what they look like. We'll look at the negotiated rates. There's fee schedules and percentages and all kinds of different types in here in the data. Everything's fee for service. There's no bundles in here, but there could be. So it's important to always look and understand what you're looking at here. And we're looking at Aetna, Blue Cross Blue Shield of Texas, and United. I think that's great. We've got other things like the place of service. Really important, right, is the work being done inpatient at a hospital is probably going to be a higher rate, or outpatient, or some other place of service, an office visit location, those kinds of things. So let's look. We're going to click on the data tab here and see what this looks like. Okay, so I was my brain was being scrambled seeing this in the JSON in the JSON format. That interesting hierarchy, but here's how I want to see it from an analytics perspective. So I have the payer here, the NPI, here's the billing code, here's the rate, right? So Aetna has this particular rate. Interesting, here's one, same NPI here. So we've got very different rates. Notice but the place of service codes are different. So we can look and see the billing class, place of service code, the TIN value, the expiration date, right? These are evergreen contracts. So things can be updated here, but nothing's set to expire right now. And then, so here's what you were showing earlier. Here are the plans, right? And then we've got plan types in here. So you can see, I think it's actually the exact one you were talking about, Jerry, Aetna Choice POS 2. So yeah, nice. So here it is flattened, here it is in rows. And so if I wanted to look at, for example, the cities in Texas and the median rate or the average rate, we'll do median for these payers. For institutional rates, 27447, and let me filter out, good, okay, all the billing modifiers. And let me look at just PPO plans, for example. There we go. So pretty cool slicing and dicing. And then if I want to drill in to Dallas and then drill into the organizations in Dallas, there they are. Really cool stuff.
Yeah, so this is the type of stuff that you can do with this data once it's flattened out. Obviously, it's not really usable in the JSON format that it comes in. But once it's all flattened, then there's also some enrichment that we're doing. Obviously, there's no organization name in the data. There's no city name in the data. Even the billing code names are all different depending on what the payer puts in there. Being able to look at different taxonomies and go across taxonomies, that's important. But these are all things that we add to the data to try to make it much more usable. And we're continuing to add more of these capabilities to our stack, and then just in general finding other information, metadata, things like that. Claims volumes, for example, is something we're working on, right? So being able to add that in, just trying to add more context to this data to make it even more useful and usable.
Makes sense.
Cool.
Very cool.
So as far as hopefully we've demystified some of this, I'm not sure if we have.
I feel definitely demystified there.
Okay.
We know that there's different laws for payers and hospitals. That's important. Different rules. You have to understand what the data means. It takes kind of special technology and approach to be able to get it and hold it. It's very expensive, very time consuming. That's why a lot of organizations have popped up. That's why we're excited to be solving this particular problem. It's a really big, complicated, hard problem. And so if we can democratize this information, if we can make it so that it is easy for everyone and they can focus on whatever they're trying to do, from network expansion to rate negotiation to whatever it may be, some kind of repricing strategies, ensuring that their performance improvement from a revenue cycle perspective, ensuring that their processes are up to date with the highest contracted allowed amounts, so that they're just kind of maximizing their operating cost and operating spend and those kinds of things. I mean, there's just so many different things to be able to do with this information. And so, like you said earlier, we're just trying to make it easier and make this data useful.
Yeah. And that's what we focus on. Just trying to, it's the usefulness.
Yeah.
There's obviously a big technical hurdle of being able to get this data. And there's been a couple of companies that have been able to, we don't know specifically what they have or don't have, but we know that there are other companies that have this price transparency data, and getting the data into a flattened format is one thing, but being able to wield it and then make it useful is really the challenge. And that's where we need to work with our customers to understand what they're trying to do with the data and what the various different use cases are. And there are definitely a lot of them. And so we try to build towards that. And it's still relatively new. It's a new space. Price transparency data is definitely something that's going to need to be part of every healthcare business. If you're in healthcare, there's going to be a certain point at which you're doing yourself a disservice if you're not using this data.
Yes.
In some capacity. And hopefully this is something that can just lead to at least more normalization in pricing, and hopefully reduce the overall cost of healthcare, or at least shine a light on like what costs what and why.
Yeah, let's start there. Yeah, let's shine the light, get the transparency, increase the trust, and there will be normalization at least of these rates over time. And I think that's really excited to see a real MRF and see, wow, okay, this is a little bit convoluted how it's out there. But then how simple you can make it just in that nice flattened structure. And I can do analysis and aggregate and sum, which is what people need to be able to do with this. So maybe as a next conversation, we could talk about some of the fields in detail, maybe explainers for those and what they mean. And I'll definitely check out that documentation on docs.payerset.com.
Docs.payers. Good plug.
Right on.
Yeah. All right. Well, it's been real.
Thank you, Jerry.
Thank you, sir.
All right.
Talk to you later.
All right.